Your Aims exam is near, so our main motive of this short session will be to discuss the recent Aims pattern question and anticipate few more that can come in your future Aims examination. This is Dr. Shivam. Demands your few crucial minutes for today to be with me and get the concepts that are very important. Now, before moving to the session, two reminder for you is if your plan A fails, remember that there are 25 other letters still left. So if you are falling at some way, find other ways to move ahead. Because if you stop at any point, then the things will become more difficult than becoming easy. So plan ways, find ways, and move ahead. Focus on what you want from your this dedicated study this time rather than on the difficulties. When you focus on your results, when you focus on good things, you get good. So never forget that you already have too much of things. You should be grateful for that. So maybe your way to success will come from the concept of abundance. So don't ever pity on yourself. Find ways, be grateful, and you will face success. That is my guarantee. Now, moving to the first important question. Topical treatment for recurrent respiratory papillomatosis includes acyclovir, cidofovir, zinc, and ranitidine. Now, to answer this question, you must know some basic concepts of recurrent respiratory papillomatosis and its treatment. The answer here is the cidofovir as topical because it is an effective way to treat recurrent respiratory papillomatosis but not a definitive way. These are some supportive modality of treatment which are used for treatment of recurrent respiratory papillomatosis. And what is cidofovir? It is a nucleoside analog with broad spectrum activity against a variety of DNA viruses. Adverse effect is renal toxicity. So one future anticipation question is cidofovir. They can ask you in some way its toxicity, that is renal toxicity. Now another question related to it is most common benign tumor of larynx in a child. Benign tumor most common in a child. Age is given 2 to 5 years. The answer here is again juvenile laryngeal papilloma. Now you must remember that these squamous papillomas or these papillomas are benign in nature and they are the most common benign tumor of larynx, and that is why we are talking about it today. Juvenile onset recurrent respiratory papillomatosis. If you see this RRP, these are basically of two types: juvenile onset and adult onset. Juvenile onset are those that occur before 12 years of age, and adult onset are those that occur after 12 years. More commoner are the juvenile onset recurrent respiratory papillomatosis. Some important points that you should know with regards to your exam is these have a etiology of HPV 6 and 11. That means these HPV 6 and 11 are the strains that cause juvenile recurrent respiratory papillomatosis. And what we see multiple sessile or pedunculated friable papilloma that bleed on touch in the larynx. Now if you see, we have here, these are multiple papillomas over the glottis region, that is over the vocal cords, and in serious cases these might obstruct the laryngeal inlet, and in those cases we might to do emergency tracheostomy to save the patient. So although we should avoid tracheostomy in these patients as it has chances of the disease being spreading to local regions, but in cases where we cannot avoid tracheostomy like patient is in stridor, then in cases we have to do tracheostomy to save the life of patient. So microendoscopic CO2 laser excision of the papillomas are the treatment. Another ideal treatment is with the microdebrider. So under general anesthesia, with the use of microdebrider, we remove the papillomas so that we can reduce the disease burden. But as the name suggests, these are recurrent respiratory papillomatosis. That means these have a tendency to reoccur. That means they will be reoccurring after short interval. So most common site is vocal fold. They can also be found in other parts of larynx like nose, pharynx, trachea, and the presentation will be of course hoarseness. As these are present on the vocal cord, it will cause hoarseness and later may progress to inspiratory dyspnea and stridor may develop. Interferon alpha like cidofovir is also one of the treatment and recurrence is common as we already talked. So this also shows you a picture of recurrent respiratory papillomatosis in a child who is intubated. So if intubation is possible, we intubate, otherwise we do the tracheostomy to save the life of patient. So the lesions are typically grape-like laryngeal papilloma, multiple in nature, and the age is peculiar below 12 years. Patient presenting with respiratory distress. So they can give you a clinical scenario where a child has presented with a distress or stridor having recurrent papillomatous lesion near the vocal cord or on the vocal cord, and the most possible etiology of the condition. So most possible etiology will be HPV 6 and HPV 11. Provisional diagnosis will be recurrent respiratory papillomatosis. So do remember this topic, very important with regards to yours. Adult onset papillomas are rare. These are mostly single rather than multiple as we see in juvenile onset. These are less aggressive and do not recur after surgery. Age is 30 to 50 years, more common in males, and arise on the anterior half of the vocal cord. Hoarseness is the symptom, but most important is juvenile onset recurrent respiratory papillomatosis. So if they ask, they will be asking you juvenile onset recurrent respiratory papillomatosis. Now another question, Kashima operation is done for vocal cord palsy, recurrent cholesteatoma, atrophic rhinitis, and choanal atresia. Now even if you don't know exactly what is Kashima operation, but if you have some idea where it is done or how it is done, you will be able to answer this. So it is basically done for vocal cord palsy, and what we do here, it is another name for chordotomy surgery. That means we create airway by removing a part of vocal cord in case of bilateral vocal cord paralysis. That means in case of bilateral recurrent laryngeal nerve palsy, bilateral abductor palsy, where the vocal cords are opposed and patient is not able to breathe and having stridor, initially we do the tracheostomy. Then at later stage when we need to remove the tracheostomy and give a patient airway, we do a procedure called Kashima operation, where we remove a part of vocal cord so that we maintain the airway. So laser chordotomy was first described by Kashima. Here basically with the use of laser we do the chordotomy, and nowadays endoscopic laser chordotomy is done, which is the ideal treatment of choice, you can say. So Kashima operation, it is the chordotomy, laser chordotomy in case of bilateral vocal cord palsy to maintain the airway so that patient can breathe, because both the vocal cords are abducted opposed to each other. Adducted. Now this is a PGI type question, especially placed here because the topic is important. Question is structures preserved in radical neck dissection. Now we will be moving around this radical neck dissection, modified radical neck dissection, and selective neck dissection, because this topic is common for ENT as well as surgery, and they are going to ask something from this topic. So let us see what this question wants to ask. So here in radical neck dissection they are saying which all structures are preserved. The first option is IJV, carotid artery, accessory nerve, brachial plexus, sternocleidomastoid muscle. Now, this is a figure where we can see different levels of cervical lymph node. Level 1, 2, 3, 4, 5 and 6 is not shown here. Going through the different neck dissection and what we do here. So basically a neck dissection is a surgical procedure where we remove the soft tissues from the neck along with the lymph node and some other adjacent structure. In radical neck dissection, radical itself says that it is the most means radical thing. We are removing most of the things in this neck dissection. What we do? We remove all the cervical lymph node groups from level 1 to 5. From level 1 to 5. Along with 1 to 5, what other things we remove? We remove the spinal accessory nerve. We remove the IJV, internal jugular vein. We remove the sternocleidomastoid muscle. So all these three vital structures we are removing in radical neck dissection. Now, if we modify this procedure in less aggressive carcinomas, so the basic concept of doing neck dissection is to remove the cancer from the neck, from the lymphoidal region. So if cancer of oral cavity, tongue, anywhere, we do the neck dissection. So main purpose is to remove the metastasis or the local infiltration of the cancer from the neck, and that is why we do the neck dissection. So radical neck dissection is removal of lymph node 1 to 5 along with sternocleidomastoid, spinal accessory and the IJV. But anything less than radical neck dissection is the modified radical neck dissection. Now, in modified radical neck dissection, we remove the cervical lymph node, but we preserve the non-lymphatic structures like spinal accessory nerve, sternocleidomastoid, and IJV. Now, if you see, this MRND is further classified into type 1, type 2, and type 3. In type 1, we spare spinal accessory nerve and remove the sternocleidomastoid and IJV. In type 2, we spare 2 structure, and in type 3, we spare 3 structure. In 1, we were preserving the nerve, spinal accessory nerve. In type 2, we are preserving the nerve as well as IJV. In type 3, we are preserving the nerve, IJV and the sternocleidomastoid muscle. So basically this is the functional neck dissection. The type 3 MRND is also called functional neck dissection. Now they can ask you which all group of lymph nodes or which all are not removed in functional neck dissection. So in functional neck dissection, only cervical group of lymph node 1 to 5 are removed and all the three, that is spinal accessory nerve, IJV and sternocleidomastoid are preserved. So you have to remember three things: spinal accessory nerve, sternocleidomastoid and IJV. These all are preserved in 3. In type 2, this spinal accessory and IJV are preserved, and in type 1 the spinal accessory are preserved. So preference, if you want to give preference, spinal accessory nerve we give preference. So in type 1 we remove IJV and sternocleidomastoid and preserve the spinal accessory nerve. In type 2 we preserve spinal accessory as well as IJV. We cut the sternocleidomastoid. In type 3 we preserve all the three structure, all the three non-lymphatic structure, but remove the level 1 to 5. So in all the MRND we remove level 1 to 5, but we preserve some non-lymphatic structure as said here. And there are some selective neck dissections where we remove only selective group of lymph nodes. So if you see in oral cavity cancer, we commonly do supraomohyoid neck dissection. That means the supraomohyoid neck dissection consists of removal of level 1, 2 and 3. 1, 2 and 3. So this was one of the NB question. You should remember that supraomohyoid neck dissection involves removal of level 1, level 2 and level 3 cervical group of lymph nodes. This was already being asked, and if asked now you should be able to answer this. Supraomohyoid neck dissection, that means levels of lymph node above the omohyoid muscle, inferior belly of omohyoid. So I will tell you about the different levels, but just remember that supraomohyoid lymph node neck dissection involves removal of level 1, 2 and 3 lymph nodes. Now if you see for our answer in this radical neck dissection, so radical neck dissection was removing everything. That means it was removing spinal accessory, it was removing our IJV, it was removing our sternocleidomastoid. Along with it, it removes some other structures also that you should know, that we also remove submandibular gland, we remove tail of parotid, lymph nodes at the tail of parotid, we remove the omohyoid muscle, we remove some more lymphatic, cervical lymphatic and lymph nodes. So main are, all the three are removed that we already knew from the definition here, that spinal accessory, sternocleidomastoid and IJV all are removed. Along with it, two more structure you need to remember, that submandibular gland is also removed and tail of parotid is also removed. Okay, and what all are preserved? We preserve the carotid artery, brachial plexus, phrenic nerve. So every important other important things are preserved. Okay, so if we see this PGI type answer question, which was asking ki what all structures are preserved in radical neck dissection, as we remove most of the structure. But if you see here, carotid artery is preserved, brachial plexus is preserved, while we remove the internal jugular vein, we remove the spinal accessory nerve, and we remove the sternocleidomastoid. So answer here becomes carotid artery and brachial plexus. So this was PGI type question, mainly given here to discuss all around this neck dissection. Now only one thing is left, that is what are these level 1, 2, 3, 4, 5, 6 that I am talking about for so long. So you should know a gross idea ki what are the different lymph nodes. Now if we talk about level 1 group of lymph nodes, cervical lymph node, this shows you level 1, which is further divided into 1A and 1B. Our superior boundary is the mandible, lower border of mandible, inferior is the hyoid, and if you see 1A, the boundaries are both the anterior belly of digastric, and for 1B it is anterior belly of digastric, and posteriorly is the stylohyoid ligament. And now in 2008 staging, if you see here, they say that this stylohyoid muscle is replaced by the posterior border of submandibular gland. So the posterior limit is posterior border of submandibular gland, after which level 2 will start. So level 1 is submental, level 2 is submandibular, level 1A is submental, level 1B is submandibular. This is submandibular, this is submental. Okay, so level 1A is submental, level 1B is submandibular, level 2 is the upper 1/3 or upper portion of the jugular. So that is the upper jugular, level 3 is middle jugular, level 4 is lower jugular. Level 5 is the posterior compartment group of lymph nodes, and level 6 is the central group of lymph nodes. If we see boundaries already seen for level 1A and level B, for 2, the superior boundary is the skull base, inferior limit is the inferior border of this hyoid bone. Okay, superiorly is the skull base, inferior is the inferior border of the hyoid, two superior and inferior limit. Anteriorly will be again our this posterior border of submandibular gland or the stylohyoid muscle, and posteriorly is the posterior border of the sternocleidomastoid. So this is the limit for 2, level 2, that is upper jugular. For middle jugular it is very easy. Upper limit will be inferior border of the hyoid, lower limit will be inferior border of the cricoid. Here you can see cricoid cartilage. Anteriorly is our strap muscles, that is sternohyoid, this long muscle, and posterior is the, this is sternocleidomastoid muscle, so posterior is the posterior boundary of the sternocleidomastoid. So this is our level 3, that is middle jugular. Level 4 similar, in a similar way, upper border is lower border of the cricoid, lower border is our clavicle, anterior is same, sternohyoid anterior, and posterior is same, posterior belly of the sternocleidomastoid. Now moving to the level 5. Anterior border will be posterior border of sternocleidomastoid, and posterior border will be, now here trapezius muscle comes. So posterior border is the anterior border of the trapezius muscle. So anteriorly is the posterior border of sternocleidomastoid and posteriorly is the anterior border of the trapezius. Okay, and it is further divided into 5A, which is above, and 5B, which is below. The plane is again lower border of cricoid, also divided by this 5A and 5B are divided by the spinal accessory nerve, which goes from here. And in similar way, here the level 2 is divided into 2A and 2B. 2A is antero-inferior to the spinal accessory nerve, which goes here, and 2B is supero-posterior. So this is 2B, which is superior and posterior to the spinal accessory. So here spinal accessory nerve divides the level 2 into 2A and 2B. So very important. And 2B is little difficult to remove the lymph nodes from here. So that is why 2B is important, and also in rare cases the 2B is involved. So that means if 2B is involved, there is the extent of disease is more, the extent of cancer is more. In a similar way, for oral malignancy, level 5 is rarely involved. Most commonly involved is level 1, 2, 3 for oral cancer, for tongue cancer, because that is why we do supraomohyoid neck dissection for small tongue cancers, where we remove level 1, 2 and 3 group of lymph nodes. 1, 2 and 3. That is called supraomohyoid neck dissection. Okay, and the last is level 6 and 7. So level 6 is this one, which is called central compartment of neck. So central compartment, the boundaries is similar. Superiorly is the inferior border of the hyoid, inferior is the supraesternal notch, and bilaterally are the two carotid artery. So this is our central compartment, which consists of lymphatic tissues or lymph node that supply or drain the thyroid gland, subglottic larynx. So basically thyroid, trachea, these all are drained by the central group of lymph node, and that is why in papillary carcinoma of thyroid, most of the time we had to do a central group of lymph node dissection. That means level 6 group of lymph nodes are removed in most of the papillary carcinoma of thyroid, because they have a tendency to metastasize to central compartment, that is level 6. Okay, so level 6, knowing the boundaries of level 6 was also very important. Bilaterally carotid, superiorly is the inferior border of the hyoid, and inferiorly is the supraesternal notch. So these were the some important things that I wanted to convey you regarding neck dissection. It is very important but very easy once you get it. So if I have been little faster, you can just rewind and re-listen them, you will get the points. Now our final question, the main vessel involved in bleeding from JNA. So JNA is another important topic with regards to ENT, about which you should know every minute and every important question. So I have planned to discuss more things. Do join the Telegram channel, that the link will be given below, and I'm planning more to devote you some more time so that you get more benefits out of that. So stay in touch. So JNA, the main vessel. So if I ask you, can you tell me the answer? So here the main vessel is internal maxillary artery. Yes, when we remove the JNA, our first and main goal is to catch this internal maxillary artery. Why? Because our professors who taught us the surgery, they told us that surgery of JNA is like catching a snake. So if you catch a snake, for catching a snake, you have to hold the main head of the snake so that it cannot, means it does not able to bite you. So for holding the head of the snake is similar to catching the internal maxillary artery for JNA. So you all know JNA is a very vascular tumor, and most surgeons fear this because of its vascularity, and it bleeds enormously if you tackle it and if you damage it while doing the surgery. So our first step is to do the exposure, visualize this internal maxillary artery and clip it or cut and ligate it. So once we get hold of internal maxillary artery, removing JNA is easy, means becomes easy, relatively easy. So the main supply is internal maxillary artery. So it's a branch of carotid, so it's a big vessel, and means you will be able to see it once you expose it on the posterior wall of maxilla. So it is seen beautifully once you do the surgery. You should also know some other arteries which supplies JNA, like ascending pharyngeal artery, Vedian artery, sphenopalatine artery, which is already a branch of JNA, but these are less important. For now, you should only know that internal maxillary artery is the main supply of JNA, and for more discussion, stay in touch. We will be meeting soon. Till then, stay healthy, stay happy, and keep giving your extra effort, because in any way you have to do it. There is no alternate option, and you have to take next step. That means you have to enter into next phase of your life and move ahead. So try to give what is important in this phase and move to your next level, move to your next phase. This is Dr. Shivam signing off. Do let me know how things are going and how it is helping you. Thank you. Stay happy.